Good afternoon, everyone. We're glad that you're here. It's about 2 o'clock, so we're going to go ahead and get started. My name is Jim Keating. I'm the director of the Parkinson Foundation of Oklahoma, and we are so happy to be able to partner with Integris Health to put this deal on. I need to make a couple of announcements before we really get started. I don't want to take up a lot of Dr. Tartagliano's time, but the restrooms are right behind us. If you need to get up, feel free anytime. If you need to go take care of that, feel free to do that. I want to thank Kyle Millar, who's with Integris, that's been very instrumental in helping us get the logistics set up for the room. It's been great to partner with the folks from Integris on this effort, and because I think you're going to learn a lot today. There are several of you who have been in our Speak Out and Loud Crowd programs through the foundation, and we're glad that you're here. If you are not familiar with the Speak Out program that we have as we partner with Integris and as we have the meetings at the Parkinson office, we have information back on the very back table if you're interested in that, as well as the Power physical therapy program that we also promote with Integris. Very beneficial programs, and it's something that you really probably ought to take a look at getting involved with. If we do not have your email address, we probably have most people here, but if we do not have your email address, please write it down on the sheet of paper back in the back, because we send out an e-newsletter every week that has updates on all kinds of things regarding Parkinson's and what the activities going on at the foundation. And if you're not a part of that e-news link, we need to get you involved with that. So if we don't have your email, if you don't get the weekly update newsletter, please on the back sheet, just write down your email. There are also informational pieces regarding all the activities that I talked about with Speak Out and Power Up and the other things that we do back on that back table. So please feel free to grab one of those on your way out. I want to introduce Dr. Dawn Tartaglione. I got acquainted with Dr. Tartaglione this summer and realized that she is a tremendous asset to people with Parkinson's disease here in Oklahoma. She's done a number of DBS cases with great outcomes, and she's just somebody you need to know. I asked her if she would be willing to put on a seminar for the Parkinson folks, and of course she agreed to do that. And then the Integris people just jumped on it from there to set this thing up. So I'm excited to present to you Dr. Dawn Tartaglione.
Thank you, Jim. Hi, everyone. Thanks for coming. I put this here because my microphone, but I talk with my hands. So can you hear me? Is it okay? Okay. All right. I try not to get it too close to my head in case I get to moving around. Anyway, I'd like to thank everybody for coming over. I mean, it's kind of midday, so maybe if you had to drag yourself around to appointments today and things like I did, that those are through, and so you can enjoy a little bit of just some review about Parkinson's. And this is a kind of I'll kind of go through the slides. If you have any pointed questions, right, on a certain slide, you can just ask me, but we'll do questions at the end. So if you want to, jot things down too. So we'll get through it. And if you have something you're afraid you're going to forget, just throw your hand up, and I'll try to see it. Well, I'm looking at this crowd. I mean, they must be letting everybody in. I mean, I even have some patients here. Just kidding. No, I really appreciate everyone that came. And again, we're talking about deep brain stimulation for Parkinson's disease. But remember, Parkinson's disease has many modalities of treatment possible through Jim Thorpe and Southwest Medical Center. And all the Integris rehabilitation sites, Northwest Expressway, Yukon, wherever you go, all the sites, offer physical therapy, occupational speech therapy. I know there's a lot of focus on that, but deep brain stimulation is one thing, but here at Integris and through Integris Jim Thorpe Rehabilitation, it doesn't just mean that inpatient hospital over there. So there are lots of things available to you, and we hope you'll take some of the paraphernalia or the propaganda with you, and if you need the numbers, use them and call to get information. So anyway, the first thing is these are my cats doing my taxes. you try to spread out paperwork, and if you have a cat, it doesn't really go too well. Kind of interesting, cats don't really get Parkinson's disease, but these two have something wrong with them. Anyway, so today, well, this is a picture of Julie and Sam. Don't let it scare you off. If you did have deep brain stimulation, they'd have to be in your room because they work in the operating room. But they're like, put a picture of us. There you go. Okay. Anyway, I do general neurosurgery, and neurosurgeons are brain surgeons and spine surgeons usually. Some people just do one or the other, but we are trained to do brain and spine. We also often do peripheral nerve surgery like carpal tunnel, ulnar nerve. There's all kinds of different things, but generally, people say, oh, are you a brain surgeon? Well, yeah, I guess. The deep brain stimulation is a procedure that involves the brain, as you probably know, and it is specifically done by neurosurgeons. And I've been practicing 12 years. I guess this is the beginning of the 13th year. And I left Michigan. I had been there for 16 years. I did my training and then worked there in private practice and then moved here back in 2009. And so this is the beginning of my 5th year here. And once I got here, I met people like Britton Segler, Pam Verducci, and then they forced me to meet the Medtronic rep, T.W. Steele. It's gone downhill since then. Just kidding. You're going to get to see him. We're going to make him stand up. But no, what happened is there was a need for us to consider this as a service line here. There's a lot of people in Oklahoma that are all spread out. We don't have as many people as Texas or Missouri. We don't even have 4 million people. We're kind of spread out. But we realize there is a need for deep brain stimulation to be available. And with the number of people that have Parkinson's disease, just by statistics alone, certainly this was a program we thought could be successful for the hospital. But really, that's a great benefit on the side to me. The main benefit is this could really help people. And let me just tell you that 2 years ago when we started, I didn't understand it. I may not even understand it now because it's not happening to me. But the kind of thing that we're seeing with the deep brain stimulation and the fabulous improvement we're seeing in some people's lives, you just don't know it's going to affect you like that. You just don't know. And it's been really terrific. So 2 years ago, we did our first case. And since then, we've done a lot of implants. And a lot would be like not every month doing 1 or 2, but a lot would be doing 10 or 15. Maybe 10 or 15 a year or something. It's a kind of thing you can't do it every Monday, Wednesday, and Friday. It takes a lot of workup, a lot of appointments, a lot of making sure and patient selection until you get there. So objectives, we're not doing this for continuing medical education credits, but I always like to say what we're trying to do is we'll just talk about how much Parkinson's disease is out there and who gets it, as you probably know, the signs and symptoms and the medical treatments people are on, and then we'll just compare that to how the deep brain stimulation can affect and help some people and how we actually do it. And then we'll discuss some risks and benefits of the surgical treatment. So the main features of Parkinson's disease, if you're sitting here, you can roll your eyes. I'm sure you know them. But tremor. A lot of people with Parkinson's disease have tremor, as you know. It affects the upper extremities usually the most, but it can do both arm and leg on one side. It can do all 4 limbs. This is the feature, tremor, that is technically in the books, they say, improves the most with deep brain stimulation. It may be. I'm not sure I'm sure people love that when their tremor is less, but I would say being less rigid and being less bradykinetic, meaning being able to move quicker without the slowness, I think people really love that too. So the motor fluctuations, this means, during the day, as you go through your day, if you have Parkinson's, you are stiff and then you take your medication and then you maybe have some good time period, or first you have side effects, then you have a little good time period. We call that when you're on and off. But generally, a Levodopa product is the product people take, and there's many names for that. Those are Cinemets and all those products. Generally, a lot of people in the United States, they get diagnosed with the Parkinson's disease. A lot of them have already had it a couple years, but more than 1 million people in our country have it. And probably another 1 million don't know it, but they do. And then Levodopa generally is prescribed, and many people can get many years of a relief without terrible off periods where their symptoms break through, or they can tolerate the doses going up and they don't have so many bad side effects, or we call them Dyskinesias. After this period of 5 years, the natural history of the disease, and again, any of you that are here, I'm just using these numbers as the averages. Of course, your course can be different, but this is just kind of a basic of how Parkinson's goes. After that period of 5 years, patients might start to have more unpredictable things happen from the medicine and more unpredictable things happen off the medicine. And so deep brain stimulation has been done since 91, I think, or 89. In Europe, they started doing some studies. And then in the United States, it's been available for more than a decade. But again, this kind of thing, it's brain surgery. It doesn't really spread like wildfire. And it's expensive. It's not cheap for the hospital to even provide it as a service. The equipment's expensive. Medtronic, they've developed this fabulous program, but I mean, it took years, and it's expensive, and it's just important that we do it right and get the right patients for it so we can help them. And when I say expensive, I mean the equipment in the operating room, things like that. It's just very, very expensive in this day and age when hospitals, they need new heart machines and they need other things. So it's really terrific that we have it here. Okay, so treating your motor fluctuations often after that 5-year period or some time period that your levodopa product, your medication does not work, it's tweaked, it's changed, it's not doing it. Sometime after that time period, then your doctor will probably take you beyond the just the first line drugs. Obviously, you go to second line. There's many medications of which I am not an expert about the medications. Is the expert here? All right, he might come down here. We'll make a big parade if Dr. Rathman has a minute to get down here, okay? All right. So what happens is this delayed on and wearing off, and the dose isn't right, and you have to take it too much, and the body starts not to be able to absorb a big dose as well, and then it doesn't last very long like it used to anyway. And then in the brain, there are changes that happen over time with Parkinson's disease because there's no cure for it. It is going to continue. But, the medicine covers you a while. Then you got to change to new meds to keep helping it, keep giving you relief and, try to give you life that you can do things. So anyway, according to the American Academy of Neurology, 10 to 20% of people with Parkinson's disease may be in the time window or may have the right kinds of symptoms and may be at the right place in their medications that they should be considered, in my opinion, should be considered at least for surgical treatment. So how does it work for Parkinson's disease? This is what we do. Exactly what it does inside of the person is we put an electrode. It's not too shocky or anything, but I will explain some side effects. We put this electrode through a hole in your head that I drill, and then we pass it down into the brain deeper than seems natural. It is not a shallow thing, so that's why this equipment is very expensive. The equipment actually drives this lead down into the brain. So we'll go over, exact pictures. What happens is the current then is delivered through the lead, and it's believed to disrupt and kind of change and short circuit or switch around the motor activity that is going out telling you or making you show that you have Parkinson's disease. It interrupts this. We don't know exactly how, but we know it does interrupt it. And therefore, a lot of times the motor function, you think of everything as being smoother. Less tremor, maybe even less fast, and less amplitude. Less rigidity and less bradykinesia, meaning when you can get up and down, it doesn't take as long to maneuver your body. Those are the kinds of symptoms that we see improve with the deep brain stimulation. So for deep brain stimulation, I just wanted to show you, this is kind of how a lot of people are living their life, up, down, up, down, up, down, up, down. Meaning you take the medicine, you're feeling better, it wears off. You take your medicine, it wears off. On and on. And again, the people in the audience, you know more than me about that. Deep brain stimulation, when they did the big studies, they said, wow, these people are getting a total of a day where for 5.1 hours, they're better. than they are without deep brain stimulation. And just so, in case I don't say it exactly like this later, remember that deep brain stimulation is an adjunct, or it's an add-on. It is not a replacement for all your medicine. It is for Parkinson's disease, you don't just get to throw all your meds away. I wish you could, but that's just not how we do it. So generally, people are looking at a reduction in dosing or frequency, and that's usually done by neurology. They help you wean down after your deep brain stimulator is in place. And also, they can tweak your medications by what symptoms you're getting the best relief from your deep brain stimulator. And this is kind of a busy slide. I'm really sorry about that. But the main thing, it shows if you have best medical treatment alone, you get from DBS, deep brain stimulation, you get 5.1 hours. This was a study done from multiple places. It wasn't like one doctor just put it in 30 people and said it's awesome. And the medications, on average, were reduced about 25%. And we see in the office that it just depends. Some person may have had Parkinson's a long time, but they've been able to go down, about half for a while. And then we see another person that's not had Parkinson's quite as long, but they still need all their medication, but they're just, when it's turned on, then they don't have their side effects, and they're thrilled that they didn't have to go higher. A separate study, the symptoms were helped by deep brain stimulation for years. It didn't really wear off and not help as much. Now, this is a tender thing you want to remember. You still have Parkinson's disease if you have a deep brain stimulator. There will come a time that the levodopa medication and deep brain stimulation will not make you not have the symptoms of Parkinson's disease. What we're seeing in this is we like to try to say to people, this is to take you back to some other time period before that's passed where you had more relief. That's the goal of the surgery. And for different people, it's different things. So that's something that's kind of individualized, and during the office visits, we try to, help you along with neurology to, set your expectations for what you think is going to get better. So anyway, this just says if you're adding deep brain stimulation, it's pretty obvious. It says GI absorption. There's no extra meds to absorb. It doesn't, this goes right into your brain. It doesn't have to go through your whole body and then somehow get into your brain. There's no real problem saying, I forgot my medicine. I mean, your deep brain stimulation, it is on. You still have to take your meds. But there's some problems that are eliminated by this being inside of you and already existing. It's proven to be safe. There is a higher incidence of having a problem in a group that gets a deep brain stimulation implant versus a group that doesn't. Well, that should be obvious. People that get a brain surgery might have a complication or a problem, whereas a group that doesn't get a brain surgery probably won't get those. So, that's obvious. But of course, there are things that can happen, and we go over those in detail. I try to tell patients it's a fine line between you want to be comfortable if you're a candidate and you want to do it, and you have to realize there's complications that could happen because I'm having brain surgery. And the major complications that they did see, even serious adverse events, hemorrhages, strokes, 99% of the adverse events that happened from the placement were resolved by 6 months. So who can benefit? The people that can benefit are people, again, we also do this procedure for essential tremor. The people that can benefit are people that their disease has reached the stage where the daily burden is causing significant interference with function, occupational activities, like they can't work, important leisure time pursuits, they can't play golf, they can't fish, they can't put the worm on the hook, it just goes on and on. And the basic activities. We meet people that are still not even dressing themselves, they're not dressing themselves very much, it's just very difficult. So these are people that it can be a time for them to have an evaluation. How it works with our team here is you come to the office. My office is here attached to the Plaza building. Okay, get ready for the parade. Or you see me or Dr. Rathbun. I see you there. Wave out. I mean it. Put your hand up. Look around. Okay, That's Dr. Rathbun. He is a neurologist. He has an extreme interest in doing the deep brain stimulation program with us, and he programs does the programming in the office, works with medications. He's a board-certified neurologist. He's been a neurologist, I don't know, years. He's kind of old now. I don't know. Just kidding. He's a very young man. Anyway, he is also, we're both up on the 5th floor of the Plaza building, so we work together. So our offices get together. If your doctor refers you to my office or Dr. Rathbun's office, we put you in the appointment at the office where you go, so you can get assessed and organized. And so you get in and get this figured out. We do a history and physical, obviously, and we try to find out what are your worst and best symptoms and time periods during the day, worst symptoms, best times, worst times. We have a tremor assessment we do and some little writing tests. And then that happens in our office. And then if it's seeming like you're a good candidate for this, we understand your medications, how you've tolerated them, the doses you're on, how long you've had the illness. Then usually we do a short mental assessment and a depression test in the office. If you have clinical depression, it doesn't mean you're eliminated, but we do this, the Beck Depression Scale or other assessments, but then also many times we have people have the formal neuropsychological evaluation because what that has to do with is Parkinson's disease can change your brain in such ways that your cognitive thinking, even smarts, memory, things like that, are affected maybe earlier in life than they would be if you didn't have Parkinson's. And in certain ways, they can be changed because of Parkinson's that we just need to know. It helps us know, too, what kind of care are you going to need in the time period from when you get your surgery to when we finally get your battery turned on, all these steps we'll go through. We just need to know, can you do it? Can you handle it? And if you can't, is there anything we can do to help you? And who is your main caretaker? Who is going to be the person that makes sure if you have trouble, they are going to drive you in or, everything like that. This is very important because there's multiple steps and more than one visit to the hospital. So the risks are that you're going to have brain surgery. And regular risks are technically that you could have a hemorrhage that could result in a coma. You could have a seizure. You could get an infection at the site or any place along the track where the battery goes by the collarbone. The device, it's pretty good. It's very sophisticated. It's made pretty rugged, but it's still a wire covered in plastic that we're going to put in your body and hope that your body will allow to stay there. I mean, it's pretty fancy, but it's still us trying to get a foreign body to live inside of you in your body, not to push it out, meaning we tunnel it under your skin. Well, we got to make sure your skin doesn't wear through. There's many things we got to pay attention to, and those things can happen. And then we got to see what the side effects for you when we get it turned on. What's your side effect of stimulation? Now, worsening of tremor or speech impairments. I don't want you to read that and be like, okay, I would never have something that could do that. We're talking about even on a small scale. When we do programming and things, and Dr. Rathbun, knows more about the fine details of that. Also, my physician assistant, Alex is back there. You can look. It's okay. Stand up because you're tall. Okay. Okay, so Alex also, he does tremor assessments. I mean, he does everything in the office too. And what we do is sometimes, when Dr. Rathbun is going to program you, or we're checking your battery or something, if you have one, what we do is, we say, okay, your tremor is down. There's some fine points of it. Sometimes, then your speech isn't completely perfect that day when we get your tremor where you want it. So there's things to consider because it affects all your Parkinson's disease symptoms, subtly, some just more than others. Like, for instance, the tremor, a lot of people, get that relief. And then if you fall a lot and you have bad problems and a lot of tremor and certain kinds of the rigidity and certain kinds of the slowness of actually placing the feet, technically, deep brain stimulation does not technically change your fall risk. You still are a fall risk. The legs and the walking, it is not the most affected. It's the least. So many times we have people, we need their family to come so we can say it again and say it again. Remember, the walking does not get as good as the tremor and the eating and the moving around and the dressing yourself. We have to go over it and over it, sometimes to help you remember. Does the walking improve? Yes, because you can go faster. You can put your legs down where you want them. They are not stiff. They are not stuck often. But, we just try to help you remember. The upper extremities, face, those are things we see change the most and improve the most. So this is how we do it. Pre-op, meaning outside the hospital, you come in and you have a special stealth MRI. If you take your medicine for Parkinson's and you can't hold still, then we have you have anesthesia for it, because you have to hold still for this stealth MRI. So it's a long MRI kind of, and then you go on home. Those images are sent to the operating room, to our stealth machine in the operating room. That's going to be compared to the CAT scan you get on the day that you come for the stage 1 procedure. So then you're going to come to the hospital on your assigned day. You're not going to eat after midnight. And then you're going to come that day, and hopefully you won't have taken meds, and you will have your Parkinson's symptoms pretty loud and clear. Then we're going to put a frame, Alex and myself and our Medtronic rep, T.W. Steele, and sometimes our physicist, we get the frame on your head, and we stand back and look at it. We make sure it's on your head exactly how we want. And by on, I'm saying on, but I mean screwed into. That's what I mean, really. Anyway, that goes on, and then we take you over to the CAT scanner, and you get a special CAT scan that then is sent to the operating room also. Then the CAT scan and the MRI pictures in the room are merged. And that's the information that we use to determine exactly how we're going to put your lead in your head deep in the correct spot. So most of this time, you are awake. You get little cat naps, but you don't have a breathing tube that day. Then you go to the ICU, and then you go home the next day. And 2 weeks later, there's other stuff that happens in between, but mostly you're at home for 2 weeks. Then you come to visit us in the office. We check everything, and then you have your stage 2 surgery, where you go all the way to sleep, and we connect your leads to your batteries, which we put in that day. And then you go home, and then 2 weeks later you come back, and the swelling is down. Then you have your appointment with Dr. Rathbun, and then he will do your programming. Yes, Pam? Come on up. This is a perfect time. Dr. Rathbun kind of has a day job, too. He's not just like DBS man. No, he's as a neurologist in the hospital, they see all kinds of strokes and different kinds of illnesses. So he's over there today, but I'm so glad you popped in.
Yeah, I knew I was supposed to stop by.
Oh, no, it's okay. Let me go to some stuff and show him some things. Hang on. Well, maybe, I don't know.
I'm sorry, I am on hospital call this week, which means I get to respond to the emergency room, and there's been a lot of people needing neurologic
unfortunately, right.
stuff this week. So, but I wanted to stop by, and support Dawn and let you guys see us. And I love doing this, absolutely love it. And, we're always there to answer questions in the office, and if anybody has any quick questions or something, I will try to answer. But,
yeah.
I think...
I was just putting this slide up for you, so if you had any questions to ask him about this right now. But, for instance, this person has her new battery here right under the clavicle, like where your pacemaker would go. She's got them on both sides there, so she holds that up. If you're capable of holding your own, you can hold it, or we can hold it for you. And then Dr. Rathbun would be this half-invisible person, and he has.
It's very hard for me to be invisible.
No, he has the programmer there where he can make a printout, but he can adjust the leads. The piece I insert into your brain has 4 leads that communicate and can be turned on and off, and then he organizes that. And so that's a programming visit, and. The batteries last from 2 to 5 years. Oh, see, that's the end. It's not the end. Okay. But anyway, so I didn't know if anybody had any questions. Again, we all work together, and he does the programming, and the patients seem really happy with it. Any questions right now?
Any trouble clearing the airport?
No. Well, the thing is, they can feel it. if it, you know what I mean, if it made the thing go off at the airport. But now the screeners, you know, where you go in like this, the X-ray ones, I mean, it sees the thing, but it can see that it's inside of you.
And
So
you have your own programming that you can turn the device off and on. And for some folks, we will program in some settings in there where they can actually adjust up and down a little bit. But if you ever think that, you know, that your device has gotten turned off, you know, accidentally, or that your settings were somehow changed, because it is possible, you're right.
it could change a little.
Then, you know, you always want to keep that programmer with you so that you can turn your device back on. But if something still doesn't seem right, then you always need to call, you know, the Medtronic rep or, you know, or the offices, so we can just check and make sure settings are normal or back to where they were supposed to be.
Usually your own, you know, you can turn it back on. It'll turn it to what was before.
Absolutely.
But, you know, if it wasn't right, then you just make an appointment and come in if you're like, I don't think it's right. Awesome.
And did anybody else have any, you know, like I said, I'm sorry, I know I just swooped in.
Oh, no, we're lucky you could come by.
Yes.
If you were advised the patient needed to step up in medication, would you give new medications over and above doing that deep brain stimulation?
Well, specifically, the deep brain stimulator for, are you talking about Parkinson's disease? Okay, is, you know, it's not even really indicated until you're starting to have some significant side effects or, you know, from your medications, decreased on time, you know, a lot of dyskinesias, or just your quality of life is going to have to be starting to change significantly because we're not able to control it with medication increases or adding a medication. So we're not even going to look at a DBS until you're already kind of peaked out, or you're right where you need to, you know, you're doing about as well as you can do with your meds and you're just not doing well enough. Does that make sense? Okay. Any other questions,
Any other questions?
guys?
Do you take programmers? Would you program? I mean, I've had Texas. I go to Texas to Houston every time I need to be programmed. Would you take?
Oh yeah, we would love to
Yeah, we take
take
referrals.
care of you.
We
Absolutely.
take referrals. If you have it, you come over.
Like I said, this is my favorite thing to do. There's not a lot of things in the practice of neurology that you get to see this kind of gratifying results. So I'd be happy to see programming patients all day long, every day. So anybody that, you know, is looking somewhere closer or something, and, you know, we're happy to do that.
Yeah, you don't have to travel.
Does it usually take a while for a new patient to get that set right?
I will tell you that these guys do such a good job. You know, positioning is everything. With this DBS, it's just like real estate. You know, they say location, location, location. Gentleman here, he can tell you that without even turning the machine on, you can have such dramatic results, sometimes just if the location is exactly right, just from getting the electrode in. And then when you turn it on, we usually program you pretty frequently over a period of 6 months or so, every month, or, you know, every 4 to 6 weeks, just tweaking things. But we usually get you pretty squared away within the first visit or two, and then after that, it's just kind of, you know, just playing with it a little bit. So, a couple months.
Any other questions?
I'm a retired electrician. Is there any problem being around transformers and radar or radio waves during all this? If the candidate goes through with it?
You know, I don't know how to answer that question. I've never had somebody that worked, so we can get that answer for you. Mm-hmm. But do you know TW?
The question.
He's a retired electrician, but is there any issue with working around transformers?
Absolutely not. The new technology of battery variety that goes in. The only two things that should turn off, and I never say absolutely because obviously we're talking about technology. The only thing that should turn off is Dr. Radcliffe's physician programmer, or there's a personal patient programmer you get as well, postoperatively. These are made so outside interference shouldn't affect them at all. But again, I mean, it depends on how powerful the source that was.
Thank you. That's T.W. Steele. Dr. Rathbun, thank you very much for stopping by. We really appreciate it. That's a good job, you guys. Now T.W. Steele, the rep, thanks for clapping for him. No, T.W. Steele and Farah, I see Farah, they work for Medtronic, but they're not just selling it. They're here to help you. That they help our patients so much. They help the other doctors. They help your doctors know who to think about to send. This is not a line of work where we're just like running the mill. I mean, they work really hard to build relationships, and so your doctor would know and feel comfortable. And even, Alex and I and Dr. Rathbun, I mean, we try to build the relationships. Yeah, I mean, Medtronic makes it. There's no other company that makes it, but Medtronic has such a good product, and they have a vested interest in the patients. I really think that, or I wouldn't do it. I'd just be like, I don't want to do it. I got other stuff going on. So anyway, let's go back to a little bit of stuff about the surgery because it's more interesting to me. Just kidding. Okay. So you see us in the office, and then, okay. So stage 1 is like stereotaxy. Anyway, I'll just tell you what happens and show you this slide. Okay, so you're awake, but you don't have to be scared. You're having your Parkinson's that day. Your symptoms are strong because you don't take your medicine that day. Some people can't take their medicine for several days. So in pre-op, we numb your skin, but it's true, like you're awake. But what it is we numb your skin, and then at these 4 spots, here, here, and then here and here. So I don't shave your whole head, unless you want me to. I actually don't really shave except right up here where we'll be working. But this person, he might be mostly bald, but anyway, they're just showing that what it looks like. So this frame, once it's screwed into your head, I know that's weird, but it's not like it's so heavy you can't hold your head. But plus, you get to lay on the bed, and then we move you over, and you'll be flat on your back. We scoot you on over to the CAT scan table. You get your quick CAT scan, then we scoot you back over and help you. Then you go back to the preoperative area, and your family can hang out with you there. Because we go to the room, to the operating suite, and we make sure we have everything perfect. We even have a whole, it's not like a fake head setup, but we have a whole nother frame like this that sits on a frame that we practice what we generate. We're going to generate X, Y, Z, arc, ring. We're going to generate exactly the spot where I'm going to drill the hole and then start the lead out into your head. The machine doesn't pick where it goes. I do. The only thing our little driver does is it takes it down straight to the place that we've determined it goes. So we're in the room looking at your CAT scan and your MRI that we merged, and doing some calculations and looking at anatomy, and then we are writing on the board, big as it can be, exactly all the numbers for left and then right. If you're having both sides, and some people need both sides, some people don't, but we usually would do left first, so that would be the top row. We'd write all the numbers. And then that helps us determine up here on the top of the head exactly where I'll make my little line, a little incision, and make the hole. Okay, so again, this is what it looks like, the MRI side and the CT side. And hopefully it's only been a week or two apart and your brain looks the same. But anyway, it does. And we merge the pictures. Because each of these has its advantages that help us know what's going on. The CT shows us where you are in space because it's done with the frame on. And then the MRI shows us exactly what your brain looks like and the detail of your spinal fluid spaces. See the black spaces where the wrinkles are in the brain? That's where your spinal fluid is. And I have to see where I'm going to enter. Am I going to enter through this little area? I want to make sure I don't touch this. There's certain things I have to know. So that's what we look at in the room and make our plan and pick our entry point. So the target in Parkinson's disease, meaning where am I putting the lead? And that was very nice of Dr. Rathbun to say we do a good job, but we really take this seriously. I mean, we do not want to pass this into your brain over and over. We're going to get it. And so we are very happy that our team in the operating room is the same people every time. Love them or not. Just kidding. We're always like, love them or leave them. But no, it's so terrific. We want to make sure we get this into the subthalamic nucleus. There are also applications to have it placed in the globus pallidus interna, but we do the STN. And that's just the name of the little bean area where we are going to put the lead. So the stealth is the system that helps us localize the target, like helps us pick on this person right at the center of their red, right in here would be the spot, and it picks it in all the planes. And then, well, that's a fancy slide. There we go. So on this person, this just shows with the computer, this is where we're going to go right here. Not here, not here, not here, not here. Right there, just there. And I mean, it's exactly there. Within less than a millimeter, exactly. So direct targeting is what's allowed. It's so fabulous. We're going to pick the exact spot we're going in, exactly how we're going to go down, exactly how we're going to get there. Then we bring you to the room. You don't have to be in the room all that time. In the room then, well, these are some of the pictures we can see and make the plans for where it's going to go. Once you get in there, we recheck and recheck, and then we'll go ahead and you relax a little bit. We give you a little medicine, anesthesia does, and the whole time like you're warm, you're covered up, and usually people actually get hot because we're putting blankets all over them, trying to be sweet to them. But up here on your head, you have a plastic drape on your head, and I'm up there, and you can hear us talking, and Alex and I are talking, and making fun of the music, and just it's kind of it's really kind of like not annoying to you, and we don't it's not loud in there really. We just are doing it, and then I make the incision in your skin, and then drill a little hole, and people don't seem to be stressed by it. I just tell them, okay, you're going to hear the little sound. I mean, they do. I don't think it gives them a lot of stress usually. You're kind of tired at the end of the day. It's a long day, but then we go ahead and pass the little guide. It's a little guide that goes into the brain part of the way down. Then the electrode goes in there, and then we drive it. And driving means the machine we monitor on a computer, and TW and I and Alex, we look at that, and as it goes through the brain, the waves we see on the computer tell us what part of your brain it's traveling through, and we travel it down to where we want to go. And then we have you participate and show us some things. This is what it looks like, but actually we uncover the face a lot here, and we do a tray up here, so then you can see, and they can look under there and make sure you're comfortable, or scratch your nose, or But this is what the driver looks like. Our frame is more modern than this. Don't kid yourself. It's fabulous compared to this one. But this is how the driver looks. That's going into the head. And then we ask you to perform some tasks. When the lead is down where we want it to be, we'll stimulate it and see how you do the tasks. And again, this is what they don't have to pay for this part. It's too awesome. This is the part where people that haven't written their name in 30 years write their name on a piece of paper. I mean, it's emotional. I don't even always go down by the feet anymore because it's emotional. It's really a lot. We have people show us how to open, close their hand, hold a water bottle, pretend like you're going to drink it. It's, we stimulate that area, and it's really what makes it worthwhile. Then we do all those things, and when we're happy with the leads and the placements, we use TW's expertise and the physicist, and Alex and I having people do the tests. A lot of times, too, at the head, we make sure everything's still safe because, you have a little hole open in your head. You have a little driver in it. And then we go ahead and decide the leads in the location we want it. And then that side's completed. We just put a little cap, close it up. We tuck the lead back here. I was working here. We tuck the lead back here because later I'll just find it, and then I'll connect it when I run the battery. And then we take you to recovery. When we stimulate in surgery, we ask you questions about all these things too. On the stimulation where we put the lead, if you feel a cramp in your face, we say, oh, did it pass? And you say yes. So just some testing. I've never had a patient say the testing was like horrible or anything like that. I mean, it's just during it, we're just talking to you. It's not like the stimulation during it is like so strong or something. It's terrible. It's not really like that. We go ahead and we always say measure twice, pass once. That's the truth. We put a little cover on that little burr hole that holds the lead, and then we tunnel it behind and close it up and move to the other side. After the second side is done, then we go to recovery. Then in the recovery room, they're just, we take the frame off, and in recovery, you sit in there, and people usually go ahead and take some of their meds, because you still take meds. And because these leads now are in you, but they're not hooked up to anything yet. They're not turned on. But again, Dr. Rathbun was very complimentary, saying that, when we put it there, people will see sometimes some changes already. So that is good. And then you go to the ICU for that night. Post-operatively, this is what it looks like. This person has 2 that go down to here. There's what it looks like on the cross-section view of the CAT scan. Usually 1 night in ICU. If you have another thing that comes up and you're not ready, then you can go out to the regular floor and putter around a bit. We try to make sure you're doing okay. And then you at home, you can't be at home just willy-nilly doing stuff. This has to heal. Then we have to make sure everything's going good, no infections, so that in 2 weeks you can come back. Now, some people are goofy, but I don't know. We're not curing goofy, I always say. But people sometimes, from having the lead pass on the left side, they are a little bit silly. It's not usually a real stressful event, but just, from having it passed sometimes. So that's why you have to have a caregiver, for the first couple of days. You're not driving a car the first day, the first 2 days after or something. So we want to make sure that they take their medicine. Some people feel like the lead placement helped them and they don't want to take it. Just so you know, I don't want to hear it. Take it. You have to be compliant and take it. We don't want something to happen. We don't want you to fall. We don't want you to, you know what I mean? You've got to do all the things. Then again, you've seen this slide already. After you get your IPG, we call it, or the pulse generator, the battery, those 2 batteries go in at 2 weeks. You come to the office at 2 weeks minus 1 day, usually, and Alex and I check your head. We make sure that healed. Then we say, okay, you're good. The next day you come and you go to sleep, and we go. We take you to surgery, and we hook them up and tunnel it down, and it goes under the clavicle. And then you go home that day. And then about 2 to 3 weeks after that, we check those incisions, and then you go for your programming appointment, and your batteries get turned on. So the whole event, it can be 3 to 5 months, meaning from when you come and meet one of us and do neuropsych testing and get your stealth MRI and, and cardiology clearance. There's all things we check out. The whole event can take 3 to 5 months. So, we try to help get you in for a meaningful visit, as soon as we can. So, the device, again, you have your own programmer, and Dr. Rathbun has one. In our office, of course, we have a backup system, too. Alex could program in an emergency situation. Generally, people kind of get, like Dr. Rathbun said, you come for a few times, but then you live. You don't have to just get it checked every 8 weeks just because. And as far as us, the surgery side, I'm like, yeah, call me. If your wires, they come out through your skin, if you get a bad infection, you think something's wrong, please call us. We don't want you to have your stimulator taken out, but we don't want you to die from a bad infection. Occasionally a person will have one a long time, and something will go wrong, and they just don't want it out. But no, if the wire's showing or something, you got to say something. So we try to make people promise, and we try to make their family, vigilant, because we don't want to disappoint you. But it's our job to take care of you. So sometimes we have had complications. This is not like, oh yeah, I'm not going to stand up here and be like, oh yeah, I'm a neurosurgeon, but we don't have any complications. Oh no. We have had we've had very few compared to national average. But we've had episodes where we've had a broken lead. I've cut a lead when I was trying to connect it to another one. We've had a patient with a bad infection before. a bad infection, like in the hospital, and then had to have a PICC line. Serious. So, things happen. But in this practice, what I like is my partners that cover me, they don't do deep brain stimulation. But on the weekend, they can save your life and get one out of you if you get sick. We work together. We just have a really good team, and our offices understand the stress you're under. When you need a battery replacement, you feel stressed. Call, and we'll just try to add you on. We'll try to get you in. We'll try to, we try to help you. So if you already have one, if you want a battery replacement or programming, you just call and say, this is what I need. TW Steel and Farah, they work for Medtronic. They try to help the patients get to us that need us, and we just do what we got to do. That's my husband kiteboarding. Old man now. No, just kidding. This is recent, but. So over on Lake Hefner, when you see him doing that, he loves that kiteboarding. So anyway, I just can't resist. I have to tell you that it's probably a huge HIPAA violation. I don't care. I'm kidding. Don't record that. But anyway, one of my patients is here. It's very exciting. Thanks for coming. Anyway, he's up here. I won't make him do any tricks. But thank you for coming. Are any of my other patients here? Hi. Yeah.
Why
I don't know what you mean exactly by quit. The battery wears out.
Well, I got the impression from what you said earlier, this is almost like a medication. It lasts so long, and then things are going to go back to what it is.
Well, then I communicated that poorly. Let me verify that. Thank you so much for bringing that up. What I'm trying to say is you still have Parkinson's disease. If you're 50 years old and Levodopa product, Cinemet, whatever your product of the year is, whatever's working for you, when it's not working for you, but Levodopa still helps you, then you're a candidate for deep brain stimulation. What I was trying to explain then is we know, though, that you still have Parkinson's disease. And we've met a few patients that their deep brain stimulation has worked for them a long time. They've had 3 or 4 battery cycles. Maybe their battery has to be turned on enough that every 3.5 years or so, they have to get a new one. And that's how it works. It's a battery. People go, I thought it lasts 5 years. I go, well, it depends on how much you use it. It depends where we have to set it. But what can happen is we've had a couple people when we started our program that had been to other places, and they said, oh, my old doctor, he didn't want to change my battery. And then we check the settings, and we say, well, it's dead. We'll change it. But then what was really going on was the patient is now much older, and even when the battery's on, even when it is working, and the medicine's on, their Parkinson's has advanced so much that Levodopa and deep brain stimulation are not covering it. She still, got 14 years, but it didn't quit. It's just that this really works for people that Levodopa works for. So if you have been on Levodopa and you're just going up on doses and you don't like those side effects, those are people that often then they send to us because those are people that deep brain stimulation help, because you won't get more side effects, but you'll be able to have that with your Cinemet. So it's hard. What I was trying to explain really is we're all going to get old. It's just going to keep going. This, they have found that in 5 years, 8 years, your brain doesn't just get used to it and then it quits working. It does not quit working like that. Any other questions? Yeah.
Does this help the side effect of sleepiness? Like, you take the pill and you wait an hour to eat your meal.
Yes.
And then within 30 minutes after you eat, then you start to have the sleepiness or the
yes.
drowsiness. Does this help that?
Yeah. Well, the reason this helps side effects is because if the side effects are from the medication, if it's Dr. Rathbone would help you figure out exactly if it's a medication that you could back off of that DBS could help. But that is the point, that a person on the average gets 5 hours a day where you don't have those kind of side effects. You don't. I mean, it might be 45 minutes 6 times a day because you're taking your med 6 times a day. Oh my goodness, you don't have to take your high dose med. You get to take half so you don't get that side effect ever because the DBS kept you going in between. But people that have a lot of side effects from drugs, to treat it, I mean, they love this because they don't have to go so high and so low. And again, we have a compliance problem here. People don't listen. I know that. We have compliance problems because people think they're so awesome they don't want to take their meds at all from deep brain stimulation. But we're like, no, we want to smooth you. You got to help us too. Usually you need some meds.
It just depends on how much the probe helps compared to what they
Exactly.
get back the medication.
Exactly. And also, when we put it in, again, it's real estate. It's location. And we take the time for that placement, and we really, it's just really important. I mean, that day has to go the best for you, for it to help you long term. So we do see people reducing their medications and just kind of looking like different people.
Do you ever see people drive again?
We've had people, I had one guy drive his big rig truck to his wound check. So yes, apparently. I was kind of mad, and he had a hat on, and you do not wear a hat when you have fresh wounds. I'll go crazy. But what could I do? It's parked out there. It's running. No, wasn't it a semi-truck? Alex and I were speechless, and when I am speechless, something went on. I was like this. Why are you wearing a hat? And Alex goes, he drove his truck here. I was like, oh my goodness. But yeah, people drive. I mean, usually Dr. Rathbone when he programs, like he'll decide if you could drive, but we listen to your family. So, if you shouldn't be driving, I hope they speak up. I'm sorry, you have a question here, ma'am? Yes.
Is there an age or the amount of time since your diagnosis that you would say really probably be good?
Oh, yes. I've turned people away because they're old, but because they already had it 3 decades. They already had symptoms. There are symptoms that are not going to get better. They already had throat problems, swallowing, fall all the time. We had one person, he's been turned away at 4 places in Texas. But since we were new, he came to see if we'd do it. And I was like, well, we're not really on the fly. We want to kind of do it by the book here at the beginning before we go rogue. But no, I was looking at him. I was like, you're kidding, right? Like, we're not going to do it. And he was 90, and I felt pretty bad. But I was like, no, at that time we'd done like 4. I was like, I don't think that's a good idea. But in general, we've had people that their Parkinson's has features that we know mean the Parkinson's is not going to respond. Some of the, that's again why another reason the neuropsychological testing. We've had people that already have vivid hallucination. Their disease is at a stage where it will not help them, or they simply cannot cope with the procedure. They can't do it and follow the rules. Now, there's new literature that's going to come out that says that we need to consider it a little bit sooner in certain sets of people. There are people that are young, like maybe under 45, that they're going to come out with some guidelines, I think, that are going to say, hey, 36 months into this, if you've gone up on your doses a certain amount of time, you need to be considered. So I know there's literature to support that. Maybe we need to think of it a little sooner than waiting until a person literally, is having falls and so many things. But yeah, we turn people away. Yeah.
So what is the medication that they're on is not working?
Okay, it depends what kind of medication, because there's different classes of medication. If your medication is a Levodopa product, and you've never had a response to that, ever, it's never ever helped you in any dose form, whatever, you do not get deep brain stimulation. That's just not how it works. This works in that location, the subthalamic nucleus. Now, if you take Cinemet 6 times a day and you have a lot of side effects, that doesn't mean you don't get deep brain stimulation. You might be perfect. But all the meds that treat Parkinson's disease, that's how Dr. Rathbun helps us, by saying, okay, this one never worked for you, but we were using it for this feature. This is how much Levodopa product, whichever pill kind you take, this is how we think it will help you. So.
Because my husband's on Cinemet and on Rigidity, and he's just lightheaded all the time. That can't fit in the, and the more they increase his medication, the more lightheaded he gets.
Yeah, and that's a side effect that if you want to have him see Dr. Rathbun, he could tell you better than me. Yeah, and he could tell you better than me is the lightheadedness from one of the drugs, both of the drugs, or is it from one drug and the fact that the other drug isn't covering symptoms mean you're not a candidate, or is there just not a high enough dose available, that you can, tolerate without being asleep, to do it. So, I would recommend if you have a neurologist, you don't really want to offend them. It's a touchy world out there. People want to keep their patients close, but if your neurologist doesn't do, deep brain stimulation or has never referred a person for it, and you got to ask sometimes, would I be able to see someone as an just for an evaluation? It's a touchy thing. You don't want to upset their doctor. And we're not trying to steal you away. If you go to Dr. Rathbun for your programming, your regular neurologist can do your meds if you want. We do not mind. It's no problem. I have one neurologist that he manages everything, that their patients don't use Dr. Rathbun at all, and he lives far away. So that's how we do that. They just came for me to look at their wounds, and I sent them on their little way, to have them do it. But definitely get an evaluation. Any other questions? Yeah.
If you don't take the Levodopa product, am I understanding you right, that you're not a candidate?
Not that you're not okay, he said if you don't take Levodopa in any form, does that mean you're not a candidate? No. There are people that can't tolerate it, but it can be tested to see if Levodopa type drugs, cover your symptoms and help you, or if they have it sometime. That's what Dr. Rathbun will work with you on to see. It is the dopaminergic effect. Is the lack of that the reason of the normal effect? If it's missing, is that why you have Parkinson's? So there are people we meet that are not, We've had some patients that are no longer on a levodopa product, but it's because of all the side effects they couldn't just take it anymore. But they responded to deep brain stimulation because in a perfect world, there'd be some kind of magic dose of levodopa they could have taken. So you just should get evaluated. Most Parkinson's disease patients that we see that we turn away, it's because the time has for maximum benefit or even medium benefit has passed. So, we're not just being like we're running the mill. We want 75 people to come by. Dr. Rathman's office filled up, Saturdays and Sundays just to get the work. No, we want people to know, like, ask about it and, see if you need it. Usually Dr. Rathman will meet you, and if you're not a candidate, he'll just, he tells you. If you are a candidate, then you meet us, and we assess you and everything and see if you can do it. Then you do imaging, and then we do your neuropsychological testing, and then we go to town. Yes?
Excuse me. If you do take levodopa, what is the average time that one might expect those benefits to begin to wane?
To wane, it just depends how long you've had Parkinson's. But generally, the effects don't wane. Your Parkinson's got worse. The electrostimulation still works. So yeah, we found that like at 5 years, it's not like you got used to it or something. If you already had Parkinson's, like, if you got Parkinson's at 52 or 3 and you're 78, yeah, I'm not going to be able to help that person as much with deep brain stimulation if they have, had 6 years of many side effects already and continue just to age. We do age anyway. Parkinson's disease adds on to all our other things that are going on, and we've had to turn a couple people away because they were so sick. They had bad heart disease, they had bad diabetes, like bad, where their doctor said nope, you can't have it. So we have seen that. It's disappointing. We feel sad. We want to do it to everyone. If you could get a good result, we'd love it. So yeah.
Okay, say that my doctor recommends I see you or Dr. Rathman.
Yes.
How long does it take to get me into?
Well, Dr. Rathman, he, for instance, if you need to see the neurologist to see if you might be a candidate, usually if you call over there, he works how he's working today in the hospital 1 week, then 2 weeks he's in clinic. So a lot of times I tell people, 2 to 3 weeks, you have time to see your doctor, make sure your med list is perfect, make your trip if you're from far away, get ready and do your appointment. And then if your appointment reveals that he thinks you're a good candidate, then they call our office, and then we try to add you on, like if the next day you can come over, like the following Monday or Wednesday, we try to get you in. Because, our part takes a long time. We got to get that stealth MRI. We got to, send you for neuropsych. But again, the whole beginning, can take 8 to 12 weeks. The whole beginning, up to meaning surgery day.
My doctor recommended me to see y'all.
Yeah.
When I told him he was coming over here, he said, well, that'll be good for preliminary.
Yeah, okay.
Call him back.
And then, who's your doctor? Oh, exactly. So you'll be getting in right away. He's up on our same floor. We can't get away from him. So we have to see you right away.
Shame on you. I know him a little bit. He can run faster than he can.
That's right.
Do you put two simulators in? I just have one for both sides.
Oh, yeah, he was, this gentleman was asking, do I usually put 2 stimulators in, like a fresh person, just first one? Usually, yes, I match sides usually. But a person, there's variations possible. If the person already has a pacemaker, you can go over to the other side and put both into one. There's different things. Yep.
You can throw both sides.
Yep, you can. You can just have one where it's tunneled to it. Mm-hmm.
Mine's rechargeable for the last 10 years.
Nice. We do have people that does last like 10 years, like you. Mm-hmm. Yep. So you just let us know if you need something. You've got the numbers back there, and I want to again thank everyone for coming. I really appreciate it. I know you have a lot of busyness and appointments, and if you have Parkinson's disease, I have I know it's hard for you to get around. I mean, I can't even imagine sometimes how tough it is to get everything going and all the appointments. But I really appreciate your time. Thank you.
Just real quick, thank you so much, Dawn.
You're welcome,
for making
Jim.
this happen. And
around for a little bit, T. Doug? Do you need to leave or? Okay. Are you going to be here for a few minutes?
Yeah, I can see.
Okay. So if anybody has specific questions for Dr. T or for TW or for any other folks here, please feel free to stick around for just a few minutes. Also, remember the fall conference at Henderson Hills Baptist Church on Saturday, November 2nd. So it's a week from this Saturday. I've had several people ask about the time when to come. You can come anywhere from 8:30 in the morning till noon, and it'll last till 2 o'clock. 8:30 till noon is for healthcare providers for continuing education credits, but you can come and listen to speech therapists, occupational therapists, physical therapists if you want to from 8:30 till noon. At noon, you can pick up a box lunch and then stay and hear Dr. Cherry and Abraham Karnapuja, as well as a panel discussion with the different healthcare practitioners. So that'll be from noon to 2. If you want to come at 8:30 and stay till 2, that's fine too. So again, I'm glad that you came, and thanks to Integris and Keith and Kelly and everyone from Integris. It's been such a big help, and we'll see you a week from Saturday.
Thanks, Janet.
My question, I've taken several different medications, but the only one that is working is the one that I'm taking now, it's called tremor, and I'm up to 24 milligrams. I'm not doing any of the